All right, our number of people attending is still going up. We're just going to give it another minute so that everyone can get in, and then we'll start our presentation. All right, I think most of us are here. So hi everyone, and thank you for attending InVia Fertility's patient education webinar on in vitro fertilization. My name is Vicki, and I'll be your moderator for this informational session. I'm honored to present to you the panelists of our webinar, Dr. Sigal Klipstein, Dr. Elizabeth Puscheck, and Dr. Vishwanath Karande. Dr. Klipstein trained at the University of Chicago for medical school and then completed her residency and fellowship in reproductive medicine at Harvard University. She'll be teaching us about ovarian stimulation and preparation of the uterus. Dr. Puscheck trained at the Washington University Medical School in St. Louis and then completed her fellowship at the Medical College of Georgia. She'll be teaching us about procedures and laboratory findings. Dr. Karande completed his residency in obstetrics and gynecology at the State University of New York at Buffalo, and he completed a fellowship in the subspecialty of reproductive endocrinology and infertility at the prestigious Jones Institute for Reproductive Medicine at the Eastern Virginia Medical School in Norfolk, Virginia. He will be teaching us about IVF success rates. All three of these physicians are board certified in the specialty of obstetrics and gynecology and in the subspecialty of reproductive endocrinology and infertility. As you may know, we have 4 locations at InVia Fertility: Hoffman Estates, Arlington Heights, Northbrook, and Crystal Lake. And now that you know a little bit about us, we want to know a little bit about you. So a poll should be on your page. If you could just let us know where you are in your fertility journey. Okay, and here are the results of that poll. If everybody, has a chance to look at them. We will have other polls during the presentation. It would be grateful if you could share your responses with us. If you have any questions, please type them in the Q&A section, and we will have time at the end for a question and answer segment. Now I'd like to turn this over to Dr. Klipstein to start her segment on in vitro fertilization.
Hi, thank you very much. It's a pleasure to present this webinar to you this evening. What I will be talking about is really the first part of the process. So in vitro fertilization, ovarian stimulation, and preparation of the uterus, really critical parts of the entire process. Next slide, please. For those of you that aren't familiar, there's several steps that go into the IVF process. Typically, a woman ovulates 1 egg a month, but with in vitro, for a variety of reasons, we'd like women to ovulate multiple eggs. And so that's done by injecting a series of fertility medications, usually into the abdomen in the subcutaneous route, similar to insulin needles. That produces what you can see here in picture number 2, the production of multiple eggs. So these little black circles are follicles. They're follicles filled with fluid, and each of these follicles we anticipate will have an egg in it. And those eggs are then removed with an ultrasound transvaginally. There are no incisions involved in the process. The woman goes to sleep with a little IV medication, like a little bit of twilight sleep. Takes about 15 or 20 minutes. An ultrasound is put in the vagina, and there's a needle that is ultrasound guided, and that goes right into these fluid-filled follicles. When the fluid is removed, it goes into, you can see in the bottom there a test tube, and that's the only test tube in this whole process I know we call it test tube babies, but there are very few test tubes involved. Next slide, please. After that, the eggs are removed, and our embryologists are actually waiting to receive these test tubes, and they look at the fluid under the microscope. Within a few hours, the sperm is added, and if all goes well, then the egg fertilizes. And here in number 6, you can see what's called syngamy, which is a very neat process where the egg and the sperm, which are each one cell, combine. And here in the middle, you can see these two little circles meeting. And that's the first meeting where the egg and the sperm nuclei meet and form one combined cell, which then divides multiple times, creating an embryo. And that embryo is what we put back in the uterus in order to achieve a pregnancy. So next slide, please. In order for this to work, we have several steps. The first step is to stimulate the ovaries, like I said, to make multiple follicles. And what we use for this is hormones that are very similar to ones that our body naturally makes. It's just that typically our bodies make enough hormone for one egg to mature, and we can sort of trick the body into thinking that it should mature more eggs. And so some common medications are called Gonal F and Follistim and Menopur. Like I said, these are all injected under the skin, very tiny little needles. And typically we use 2 of these medications, sometimes just 1, to stimulate the ovaries. Somewhere along the way, we need to prevent the ovaries from releasing their eggs prematurely because there's a very small window of time in which these eggs can be removed from the follicles. If we go too early, the eggs won't be mature, and if we go too late, the eggs will have ovulated, and since they're just one cell and they're tiny and microscopic and we can't see them, we won't be able to find them. So we need to know exactly when to find them, and so we use medications such as ganirelix or cetrorelix or leuprolide, also known as Lupron, to prevent the ovulation from happening too early. Also given by injection, and we'll talk a little bit as we go through about ways in which we try to make the process easier for our patients. We have lots of ways where we can minimize the number of injections, which I think is one of the most concerning parts of in vitro fertilization to many of our patients. And you'll see what we do to ease the burden. And then the last step is to trigger ovulation. And so we know that once we give a trigger injection, the eggs and the follicles are predictably mature within about 40 hours. And like I said, if they ovulate, it's too late, we can't find them. So at 36 hours after we give a trigger shot, the eggs are removed from the follicles. Next slide, please. What is the actual process? So there are 2 parts to the process. The first part is to suppress the ovaries so that we can take over the cycle. And then the second part is what I discussed, stimulating the ovaries and inducing the follicles to grow. So there are lots of ways we can suppress the ovaries. Sometimes you can give birth control pills. We don't usually like to do that because it can tend to over-suppress the ovaries. In some types of stimulation cycles, that may be an option. And I'm giving you an example of one type of cycle that we use for the IVF process, but of course every woman and every patient has their own particular needs, and we fine-tune the cycle and the cycle type to exactly what you need, but the basic parts are the same. In the first half, you suppress the ovaries, and then you stimulate them to make multiple eggs, and then you retrieve those eggs. So in this type of cycle, it's called a luteal estrase cycle. When a woman gets her period, we check some hormones around the 2nd or 3rd or 4th day of that period, and then we wait. We wait for ovulation. Ovulation typically happens around day 14 or so of the cycle. So a week later, we check a progesterone level to confirm that ovulation has happened. We do that around day 21. And once we confirm that ovulation has occurred, we start estrogen pills. And these are used to suppress very gently the ovaries so that we can take over the cycle. And at the end of that 7 or 10 day period, a woman gets her second cycle. So this is just one menstrual cycle. And then with the second cycle, next slide, please, we actually start the stimulation portion. And this is the most critical part of the IVF cycle. So in the first part, in the first 10 days or so, we give the stimulation medications that you saw, typically 1 or 2, and then we add to that usually an antagonist cycle, that's cetrorelix or ganirelix that we showed you, that prevents ovulation. Now, in most IVF centers around the country and the world, you give these injections, these 3 injections, separate injections. But what we found is that you can actually mix them all together, and we have a nice protocol for doing that. And so instead of giving 3 separate injections in any given day, or sometimes 4 or 6 injections. You can just take one single injection, and that's really nice. One injection in the evening, that's all you have to do for about 10 days. During that window of 10 or so days, a woman comes in 3 or 4 times for blood tests and ultrasounds to see how her body is responding to the medications. What we're looking for is that those little follicles, those little fluid-filled sacs, be about 18 or 20 millimeters. So they're about like that size. When they get to that size, we know that the eggs in them are typically ready to be ovulated, and so we give the trigger injection. And like I said, predictably 36 hours later, the eggs are ready to be retrieved. So usually we give the trigger injection on an evening. So let's say we give it on a Monday night at 8 in the evening. 2 mornings later, Wednesday morning, the woman would come into our office and have the egg retrieval. How is that done? She gets an IV in her arm, goes into twilight sleep, not fully asleep, same sort of medicine as if you were to have like an endoscopy or wisdom teeth removed. And then the egg retrieval happens under anesthesia. Before she goes home that day, she knows how many eggs were retrieved. Those eggs, like I said, are mixed with sperm. The next morning, she receives a message letting her know exactly how many of those eggs fertilized. And not all the eggs will fertilize. We'll talk about that later. And not all of them develop into embryos, but typically they're grown for 5 days. And at that time, we have 2 choices. One is to transfer the embryo and wait for a pregnancy test. It takes about 9 or 10 days. The hardest part of the whole entire cycle, really, I think, is not the shots, is not the anesthesia, is not the egg retrieval, is not any of that stuff. It's actually this 9 or 10 day window where you're doing nothing and just waiting. During that window, the woman does take some vaginal progesterone, and then the pregnancy test happens. The other option is not to transfer the embryo right away, but to test it. And Dr. Puscheck will be talking a little bit about testing the embryos and why we might want to do that. But if we test the embryo, you can see here in the bottom right, this circle is representative of an embryo, and it has at this point about 100 cells. The inner blob is the part that becomes the baby, and we never want to touch that. What we do is take a few cells, 4 or 5 cells of the 100 or so cells from what's called the outer cell mass, the cells that become the placenta and the amniotic sac, and we test them. We send them to a specialized testing lab, and we can test them for a number of diseases. If the couple is known to be at risk for having a baby with a disease, we can test them for their 46 chromosomes, so we can exclude embryos that are destined to miscarry or to lead to chromosomal abnormalities. If we do that, then we need to transfer the embryo in the subsequent month. So next slide, please. So what do we do with these frozen embryos? You can have frozen embryos for various reasons. Sometimes you've had a baby with your fresh cycle in your first IVF cycle, and you often have more than one embryo, and so whatever embryos we don't use, we can freeze. And then when the couple's ready or the woman's ready for another baby, she comes and we get her ready for that cycle. The other option is that if we test the embryos, it takes some time to get that testing back, and on the 5th or 6th day of development, the embryos have to either be transferred to the uterus or frozen. And so we generally freeze the embryos while we're waiting for the test results to come back. So there are 2 parts to preparing the lining of the uterus for a transfer, and these just mimic the normal menstrual cycle. Typically, the egg ovulates on day 14 or so of the cycle, fertilizes soon thereafter, and implants about a week later. And so what we do is just try to mimic that. And so there are 2 components. One is to use estrogen. Typically, this is given with pills, and this thickens the lining and makes it ready to start accepting an embryo. And this can be given by mouth, which is the most common. Sometimes you need to give it vaginally as well, and sometimes rarely by injection or by a patch. And then you need to give progesterone, and this is given in the second half of the cycle. So after about 2 weeks of estrogen, you continue the estrogen, you add progesterone, and this stabilizes the lining of the uterus, and it makes it receptive to implantation, and it induces the formation of something called pinnipods, which in Latin, I believe, means drinking feet. And these pinnipods form for only 12 or 24 hours, and they're critical because they help the embryo find its place in the uterus and help it implant and make a connection with the lining and find its blood supply. These are given vaginally and also usually intramuscularly in the gluteal muscle. So next step, please. Next slide. What does that look like? Well, first of all, these pinnipods, if you look at scanning electron microscopy, We've been able in recent years to see what they look like, and they're these little tiny circles. And what's interesting is if you look at a cross-section of the uterus, you'll only see this during a very critical and very short window of time. Similarly, women menstruating and ovulating on their own really only have a window of implantation that lasts about a day. So we really have to be careful in how we coordinate the cycles to make sure that we're placing the embryo back right when the uterus is most ready to accept it. And here in this panel on the right, what you can see is the blastocyst, or the 5-day embryo, waiting to find these little pinnipods and finding they're almost like these little nooks, and the embryo just finds its nook, rests in it, and then these pinnipods kind of allow the embryo to connect and to form a seal with the lining of the uterus, and then the blood vessels start to form, and then there's an interaction between the embryo and the uterus, and that's how implantation happens and the early pregnancy is established. Next slide. All right, so there are a couple ways of doing this, of preparing the lining. As I said, you take estrogen usually for about 3 weeks. And about 2 weeks into it, once we know that the lining looks nice and thick, and we check that with ultrasounds, we add progesterone. And that's done typically with a vaginal cream or little vaginal inserts, and intramuscular injections. Those are in the gluteal muscle. And then typically you take 5 days of the progesterone injection, and at the end of that, you transfer the embryo. And then you wait those really difficult 10 days for the pregnancy test. So this is the typical cycle. This is something we commonly use. If the women's cycles are not completely regular, this is the best option. Women who have polycystic ovarian syndrome, for example, where the cycles are not predictable, this is a good option. But there is another option that works really nicely for women who have regular cycles. And the nice thing about this next option, next slide please, is that it doesn't use any intramuscular injections. And in fact, there's just one little tiny trigger injection that's under the skin. And so what we really try to do in so many ways at Envia is to do everything possible to make the cycle easier. And what we think part of the making the cycle easier is to not have any more blood tests or ultrasounds than is necessary, and also to minimize the number of injections. And so in this cycle, it's actually a very simple and straightforward cycle. It mimics a woman's natural cycle. And so she gets her period. We look at the hormone levels here on the left side when she has her menses. And then we wait about 14 days. During these 14 days, we do 2 or 3, usually blood tests and ultrasounds, to see that the follicle that's going to be ovulating grows to the size that it's almost ready to ovulate. When it's almost ready to ovulate, the woman takes one little injection to trigger ovulation. We know that she'll ovulate predictably 36 hours later, and we know that she needs 5 days of progesterone before the lining is ready for implantation. The nice thing about this is that the progesterone is just formed naturally from the site of the ovulation on the ovary. We just do one quick check, just one blood test 5 days after the trigger injection to make sure that the ovulation has occurred according to plan. And if it has, 2 days after that or a week after the trigger injection, we just put in the embryo. And the embryos, Dr. Puscheck will talk a little bit about how that happens and how the embryos are placed in the uterus. But that's a very straightforward thing. No anesthesia required, no discomfort. Like I said, one tiny injection, and then a little bit of vaginal progesterone, just vaginally, a cream or pills. And then you still have to wait those difficult 9 or 10 days for the pregnancy test. So that's the end of my my story on preparing the lining and the whole process of in vitro fertilization. And I'll pass it over to Dr. Puscheck, who will talk about procedures and laboratory findings.
Well, thank you, Dr. Klipstein. I'm delighted to be here talking to you about our IVF procedures and laboratory findings. Next slide. So you saw one of these pictures earlier. On the left side, you can see that vaginal probe ultrasound. This is what's happening during the IVF retrieval. So you're already asleep. We've already done a prep. You already have your IV in place, and we do a vaginal ultrasound like you've had done for monitoring the cycle. So that's very well tolerated. There's a little needle that goes right along the side of this vaginal probe ultrasound. It goes into the follicle. There's an ultrasound picture that shows the needle going into the follicle. We actually are watching the needle go into the follicle when we're doing this procedure. And then we put the suction on so the fluid can come out of the follicle, and it's collected into that test tube that's passed off to the laboratory. The test tube is containing that fluid. If you look on the right side, that fluid that's coming out of the follicle, and that follicle is made up of cells that surround the follicle, and the egg. And you can see that little egg is just kind of pushing into the follicle there until we get that into the needle and into that test tube. The test tube then is evaluated in the laboratory. And the next slide. This is where we'll actually look for the eggs. Now the eggs are looked at in a little petri dish, and we'll look to see if we can find the egg. And the egg on the left side is surrounded by what we call cumulus cells. These are cells that are actually providing some nutrients to the egg. They were around the egg in the follicle. And then later that same day, when we inseminate the eggs, we may inseminate them in this particular version, or if we're going to do ICSI, we'll clean off those cumulus cells and we can see the egg on the right side. Now, when you look at the egg on the right side, we can actually see that it's a mature egg. Now, when we're doing these stimulations, we're trying to get the most mature eggs out when we're retrieving them, but we're likely to get some immature eggs. And there are various stages of immature eggs, but we call them a GB or an M1, but that's not really important for this talk. The mature eggs are the ones that we can inseminate, and those are the ones that we're going to be looking for to help get the embryos for you. The next slide. This is the overview of the laboratory process. So on the bottom left, you see the actual ovary. Well, we're getting the egg before it is ovulated. Then in the petri dish that you're seeing where it says insemination, we're going to put sperm around the egg, or possibly put one sperm into each egg, and I'll talk about that process as well. Then we'll be leaving the inseminated eggs in an incubator for 5 days until we're ready to do the embryo transfer for a biopsy like you heard about a minute ago. Next slide. So after we found the eggs, we're going to be inseminating, which means that we're putting the egg and the sperm together. And there's two different ways that we can do that. One way is the traditional insemination. This is used for couples that have good sperm counts. And we take the eggs and we put thousands of sperm around the egg, and then we put a little oil over the top so that the sperm stay near the egg. And the egg's very smart. Once one sperm has inseminated the egg, kind of turns off the ability for any of the other sperm to actually fertilize that egg. And on the right side, we have something called intracytoplasmic sperm injection. This is typically used for couples where the man has a very low sperm count or low motility. And here you can see that the egg is being held in position by what's called a holding pipette, and that holding pipette's on the left side. And then on the right, there's actually a hollow needle that is being injected into the egg. And this is where we would put one sperm into the egg for intracytoplasmic sperm injection, or ICSI for short. Then the next would put this inseminated egg back into the incubator, and then the next day we're going to look for fertilization. Next slide. Now, during the embryo culture, the very first day, so the day after the retrieval, where it says day 1 up the left side, we're looking for a normal fertilized egg. This is also called a 2PN or 2 pronuclei. Like Dr. Klipstein mentioned, the 2 little circles on the inside, those, and I showed them where the yellow arrows are going, are pronuclei. One's coming from the male and the other's coming from the female, and then they go into syngamy for the fertilized egg. And then it'll grow in culture for 5 days. Now, we typically do not look at the embryo every day that it's in culture, because the embryo likes to be left alone while it's growing. But we know from our past experience that it's going to be going from this 1-cell fertilized egg to 2-cell embryo, and then a 4-cell embryo by day 2. And then by day 3, it should be an 8-cell embryo. Now, this is a 3-dimensional embryo. It kind of looks like there might be 4 or 5 cells there, but if you go up and down with a microscope, we'll see that it's really 8 cells there. And then on day 8, it turns into a ball of cells. So you can't actually see the divisions between the cells anymore. And this ball is called a morula. And then by day 5 or 6 of the cycle, it will become what's called a blastocyst. So that bottom right corner is called a blastocyst. And this is where the embryo is already differentiating into the parts that are going to become the baby and the parts that are going to become the actual placenta. Next slide. I've actually showed you here the different parts of the blastocyst. So there's an outer shell called a zona pellucida, and the embryo will actually have to hatch out of this shell before it implants. There's an inner cell mass, which the arrow is pointing to, and this is the precursor for the baby. And then there are these outer cells, which are called trophoblast cells, and these will become the precursor to the placenta. So on the left side, you see a real embryo, and on the right, you see a schematic, if you find that a little easier to look at. And the fluid in the cavity is called, it's called a blastocele, so it's just fluid in the cavity. Okay, next slide. So when we have these embryos on day 5 or 6, we need to be able to select the best embryo for transfer so that we're likely to get a pregnancy. And so there are different ways that we can select the best embryo. One is by looking at what's called the Gardner criteria, which is looking at the stage of the blastocyst and the quality. So this is really looking at the embryo from the outside. And I'll go over that criteria in just a minute. It's very important that the blastocyst be formed on day 5 so that it's in sync with the embryo if we're going to do a fresh transfer. Sometimes the embryo goes a little bit slower and it turns into a blastocyst on day 6. Those embryos are fine for doing a transfer, but they're not fine for doing a fresh transfer. We need to do that as a frozen transfer so that we can make sure that the endometrium is ready for that blastocyst to implant. I think you heard earlier with Dr. Klipstein that this timing is really important, so those penopods are ready for those embryos to implant. So that timing is critical. At IVF Fertility, we electively transfer just one embryo in a lot of cases, in about 95% of our cases. And that's because we want you to have the best chance to get pregnant with a healthy baby and a healthy mom. So in order to reduce the rate of multiples, we can transfer one embryo and have an excellent pregnancy rate. If we transfer more, then there is a higher chance of getting twins, and twins is harder for the baby and harder for the mom. But if we're only going to transfer one embryo and we want that embryo to be successful, which one are we going to pick? And could genetics help? So the first part I'm going to talk about is looking at how we look at the quality of the embryo to make that selection. And then second, I'll talk about the genetics. So next slide. This is called the Gardner embryo grading. This was developed in the 1990s, and it consists of 3 different scores. So the first one is a number, and the blastocyst will be determined to be either a 1 through a 6. Now the picture on the left shows the different stages of embryoblast 1 through 4, and then 5 is a hatching blastocyst, and 6 is a completely hatched blastocyst. I just didn't put those last 2 stages in there for you. But you can see the early blast is mostly cells with just a little bit of fluid. 2 and 3 have a little bit more fluid, and 4 is the expanded blast. This is the one we want for the day 5 transfer. Now there's 2 letters too. The first letter is for the inner cell mass, the one that's going to be likely to be the baby if it implants. And this is given a letter grade, either an A, B, or a C. And the best grade is A, where there's a number of cells that are tightly packed together in the inside of the blastocyst. The second letter is the letter for the trophectoderm, or the outer cells. These are the cells that are going to become the placenta, and it also gets a score of either A, B, or C. So if you look at number 4 there, you can see there's a number of different cells around the outside of that circle, and it's actually a sphere, and that's what we like to see, a number of tightly packed cells. B, if you look at the next column over, is fewer cells and they're kind of loosely packed. And then C, there's very few cells, and there can even be disintegrating. So the C score isn't going to make it, and that's too bad. So we want to get an A or a B score for an embryo being transferred. Next slide. So we'll select the one embryo for transfer, and then we'll want to freeze the remaining embryos. Or if we're going to do genetic testing, as you heard from Dr. Klipstein, that we will go ahead and freeze all the embryos after biopsy. Now, frozen embryos do great. Frozen embryos, the way we do it now is called vitrification, which is like instant glass. And it's instantly frozen. All the cells are frozen at the same time, and they do terrific. So these embryos survive this freeze thaw process and over, it's 95 to 99% of the time. So they do excellent. They can be kept in storage for as long as you want. There is no time limit. So if you want to have your first baby and you had your embryo transfer and the rest of them are frozen and you want to come back a few years later, you can do that. My personal longest has been 13 years where couples come back for their next baby and it was successful. So that time, there is no time limit for that. And of course, if you're doing genetic testing, you'll need to wait for your results and keep your embryos in storage for that. And one of the questions that a number of patients ask me is, well, how do those frozen embryos do regarding pregnancy rates? Well, they have very similar pregnancy rates to the fresh embryos. In fact, they're a little better than the fresh embryos. So don't worry, freeze those embryos, and then you don't have to go through that whole process of all those different shots to get pregnant. You can just do that last part where it's a lot easier, either with a natural cycle with some support or the program cycle with the estrogen and progesterone that you already heard about. So next slide. So embryo biopsy is a way that we can take some cells from the outer cells. These are the trophectoderm cells, and you can actually see the blastocyst on the left for each of these two pictures. There's a holding pipette that holds that blastocyst. You can see the holding pipette on the left side. And then on the right side, we're taking some of these cells out. And we usually get 5 to 10 of these cells, and these cells then are sent to the genetic laboratory, where the genetic laboratory is going to tell us whether there's a genetic abnormality or not. And we can look for specific gene abnormalities, or we can look for those things that are more common with miscarriage. Next slide. Oops, there we go. And these are the pre-implantation genetic testing results. These results typically take about 2 weeks to get back, and the report is going to give you either a normal embryo, and we call that a euploid embryo, an abnormal, which would be the aneuploid or mosaic, or if you're looking for a particular gene abnormality, or undetermined. And this just means that for whatever reason it didn't work, and we could consider rebiopsying those embryos. In addition to this genetic information, we'll also learn the sex of the embryo, whether it's a boy or a girl. And some couples want to know that, and some couples do not. And if the couple doesn't want to, then we can block that out from the report when we upload it to their file. One of the things that's particularly interesting to know regarding the genetic testing is that in women that are 35 or older, and we use a genetically tested embryo that's euploid and transfer that one embryo, there is a higher pregnancy rate, a higher live birth rate, and actually a lower miscarriage rate. And that was reported in Monet's paper in 2019 with over 600 cycles. Now, the pregnancy rate did not seem to be very different for younger patients. So that's one of the things to keep in mind. We do individually counsel our patients, and patients decide whether they want to do pre-implantation genetic testing or not. Well, at this point in time, I think it's a nice transition to Dr. Karande, who's going to talk to you about the pregnancy rates with either traditional IVF or genetic testing.
I love speaking on our IVF success rates because we have a very successful IVF program at India. And one of the things I love doing is quoting my teacher, Dr. Howard Jones, who used to say that if you persist long enough and make the required adjustments, most patients will get pregnant today with the technology that is available. Next. So what is success? Is it just a positive pregnancy test? Is it an uneventful pregnancy where there's no complication with the pregnancy? Is it an uneventful pregnancy with a healthy baby? Or is it an uneventful singleton pregnancy with a healthy baby? The fourth statement is what is generally accepted in the reproductive technology community as the ideal goal. So what are the factors that impact success rates? How do you read a success rate table? And what makes INVIA so special? I'm going to try and answer these three questions in the next 10 minutes. So what are the factors that impact success? Here they are. Maternal age is very important. The diagnosis, especially if you have diminished ovarian reserve, body weight, AMH level, number of embryos transferred. And as Dr. Puscheck said, we are now transferring single embryos in 95-96% of our patients now. And the problem with multiple pregnancies, many of our patients actually would love to have twins, but they are talking about healthy twins. Twin pregnancies, however, can be complicated, and especially with premature delivery, if you have one or two handicapped babies, then your life changes forever. So one of our mottos is, yes, you can have your twins, but have them one at a time. Next slide. So this slide shows the age distribution of women who underwent IVF. And as you can see, it's a wide range, right from 24 all the way to mid 40s. But our average, our median mean age is at around 36. And as you can see in the next slide, as a woman's age decreases, as the woman's age increases, the pregnancy rate drops and the incidence of miscarriage also goes up. So in our practice currently, under age 35, the live birth rate, and I'm going to be showing you the treatment table soon, is around 68%. But once they reach age 40, the number drops to about 25%, and then it drops to practically zero by age 45. Next. So, as I said, age is an independent variable, but there are some lab tests that we can do to assess your ovarian reserve. And the two hormones we focus on are AMH, anti-Mullerian hormone, which gives an idea as to how many eggs still remain in your ovaries, and FSH, follicle stimulating hormone, which gives an idea about the quality of your eggs. We like the AMH level to be 2.1 or higher. Less than 1 is not good. We like the FSH level to be less than 10. So combining these 5 hormones along with the age, we come up with this egg retrieval score where 11 is a good number. And in this particular patient, the number was 9, indicating some amount of diminished ovarian reserve. So if your ovarian reserve is compromised, meaning the quality or quantity of the eggs is compromised, then that will have a negative impact on pregnancy rates. Next. Obesity is a major cause for decreasing success rates for IVF programs. And this was a paper from Boston IVF where they analyzed more than 4,500 patients and looked at success rates based upon their body mass index. And pregnancy rates dropped by as much as 68% when the BMI was more than 35. So in our practice, we have an ideal protein diet program with which our patients are losing 3 to 4 pounds a week without feeling hungry or feeling tired, and with an improvement in their success rates. Next slide. So how does obesity impact IVF success rates? Well, it impairs ovarian responsiveness to the medications simply because the drug doesn't get absorbed properly, it doesn't reach the ovary. And because of that, there's an increased risk of cycle cancellation. Pregnancies in obese patients also can be complicated with preterm delivery, low birth weight, and there's an increased risk of miscarriage. There is a decreased implantation rate, clinical pregnancy, or live birth rate when compared to women of normal weight. The good news is that even a loss of 20 pounds improves the situation dramatically. Next. So how do you read a success rate table? And a lot of our patients are very well informed and they do their homework before coming to us at InVia Fertility. So I'm going to now spend a few minutes talking about how to look at a success rate table. Everybody has different ways of presenting their data, but I believe that your take-home baby rate, the live birth rate, is the number that matters. And you can look at that per cycle start, per retrieval, per transfer, or per completed cycle. You can look at the implantation rate, which basically is if you transfer 100 embryos, how many of them will result in a pregnancy? And you have to also look at a program's multiple pregnancy rate. Spoiler alert, ours is like 1% now in our younger patients. And the singleton live birth rate. Next. So our society, the Society for Assisted Reproductive Technology, has a website, www.sart.org, where everybody's pregnancy rates are displayed for the public to see. We have to prospectively report each IVF cycle and then give almost 50 or 60 data points on each patient, which are then at the end of the year tabulated and then presented on this website. So currently the latest report is from 2017, and this is InVia Fertility Specialist, where you can see we did 924 total cycles in that year. Next. And this is a very important slide because what you can see in the first column is in women under age 35, and we are looking at live birth rates per new patient. So 68.7% of our new patients had a live birth with their first cycle. And as you can see in the older age group, it drops to 62.3, 41.2, and then after age 40, it does drop. The other interesting thing here is look at our twin rate. It's 1%. Currently in our practice, I think we are getting more twins from Clomid than from IVF. With elective single embryo transfer, the only twins we are not able to prevent are the ones where one embryo splits into two. Some of our patients will demand, despite our recommending not to have a second embryo transferred, and especially patients who have failed multiple cycles, we will occasionally agree with that. But then some of them will end up with twins, resulting in the data that you're seeing on this chart. Next. So now you could go to SART's website and they have a predict my success button, which takes you to a database where they have summarized data from the entire country's IVF programs for individual patients to predict their success rates. Next slide. So when you click on the Learn More button, you get to the next slide, where you have to fill in your demographics, your age, your height, your weight, and answer a few questions. And then when you enter, hit the Calculate Results button, you get a graph where you have your pregnancy rate after one cycle, which is 55, two cycles, which is 75, and three cycles, which is 80%. Each one of you could go and try it yourself and get your individualized success rate number. Next slide. Now, pregnancy rates alone should not be used to compare IVF programs, because sometimes the best programs get the most difficult patients. But if you look at certain objective data, those can be used to assess a program. What is the elective single embryo transfer rate? What is the multiple pregnancy rate? Does the program report to SART? Are the physicians board certified in reproductive endocrinology and infertility? At InVia, we have excellent pregnancy rates. We have hardly any multiple pregnancies in our IVF program now. We do report to SART, and all three of us are board certified. So with that, I think my time is up. So I think we have some more time left in the webinar for answering your questions.
Okay, so Dr. Klipstein and Dr. Puscheck, if you want to please turn your camera and your microphone back on. We had some great questions sent to us when our attendees were registering, and we've had a couple come through in the Q&A chat box. So I'm just going to go doctor by doctor and ask you questions. So Dr. Karande, what % is the success rate of a 40-year-old woman getting pregnant with IVF using her own eggs?
The patient could very well go to the SART database and plug in her particulars and get a specific answer. But generally speaking, the pregnancy rate is in the mid-20s. However, what you should be aware of is 70 to 100% of embryos in that age group are chromosomally abnormal. So if you do the chromosomal testing of the embryos, and then if you transfer a chromosomally normal embryo, then even for an age 40 patient, the pregnancy rate will practically double.
Okay, Dr. Puscheck, let's see. Is frozen or fresh embryo best for transfer?
Well, that's a loaded question. Actually, both are great for transfer. We just don't do them both at the same time. So the pregnancy rate is slightly better with a frozen embryo transfer, but we individualize our treatment of our patients. And so we talk about what's important. And some individuals who are not interested in doing genetic testing, we may choose to do a fresh embryo transfer. Some patients might be at higher risk for some of the complications that can happen, like a polycystic ovary syndrome patient, like we talked about in one of our previous webinars, may get a large number of eggs. And if they get a large number of eggs and their endometrium might not be quite as in sync as it could be, and she may be at higher risk for something called ovarian hyperstimulation syndrome, which we don't have enough time to talk about what that complication is, but we try to minimize that risk. Then we may choose to freeze those embryos and plan a frozen embryo transfer. And when we plan a frozen embryo transfer, we can certainly make the endometrium more in sync with that embryo, and there's literally no risk for ovarian hyperstimulation with the frozen embryo transfer, so it reduces her risk.
Sorry.
Something happened there.
Yeah, hang on. I closed my window. Give me 1 second. Okay. Oh my goodness. Hang on. I'm having all sorts of problems today. In the meantime, Dr. Klipstein, you talked about the dreaded wait for the pregnancy test. Do you have any advice or recommendations for women who are in that difficult 10-day time period?
So a lot of things. So first of all, take good care of yourself and do the things you like to do. And, you know, it's hard to say, just ignore it and get your mind off it, because that won't happen. You know, this is a very important part of your life, and this is a very critical window. So, so I won't say that, but certainly keep yourself busy. I think sometimes women want to maybe stay at home and kind of hibernate a little bit, and this is not the time to stop everything. It's really the time to just keep doing all your normal activities and try to live life as normal. If you see a therapist, I think it's a good time to just make an appointment to talk about strategies to wait and find ways to manage the anxiety that invariably comes with that. There are also some apps that we recommend. There's one called Fertile. You guys help me. The app that we use on the phone. Ferticom. Yes, thank you. FERTI.com, CALM, and that gives you some strategies for coping with the wait. And there's a wonderful fertility organization that's called Resolve, and it offers many services to women going through infertility, and they have many resources on their webpage. It's resolve.org. So lots of ways to help you as you're going through, get a massage, get a manicure, go for a walk, exercise, do as much as you can, but it's hard. It's a hard window, and I think what makes it hard is that you're busy coming to the fertility center every day, and all of a sudden, getting feedback. My follicles are developing, my estrogen levels are going up, and then all of a sudden we just say, okay, well, we'll see you in a week and a half, and good luck to you. And so it's hard when we realize that.
Okay, Dr. Karande, can you discuss the difference between InvoCell and IVF?
InvoCell is something that's new, and we have just started it at Invia. This is a device where we stimulate patients, retrieve the eggs, and then load this device with the egg along with the sperm. And this device is then inserted into the woman's vagina, where the fertilized eggs are cultured for the next 5 days, after which they are removed, and then an embryo transfer is performed. There are pretty good pregnancy rates reported with this, especially in normal responder patients.
Okay, Dr. Puscheck, what is AZH and why is it used?
So AZH stands for assisted hatching. I'm not really sure why there's a Z in there, but it means assisted hatching. And assisted hatching is referring to if you remember, the embryo has an outer shell called the zona. And that outer shell, particularly either when women are getting older, it can get thicker, or if we're freezing eggs, it can get harder. And if that shell is too hard for the embryo to hatch out of it, then it's going to be a problem. So assisted hatching means that we're making a little hole in that zona to help the embryo to be able to hatch itself. And there's a couple of different ways to do it. One is with a chemical and the other's with a laser. But it really doesn't matter which way it's being performed. As long as this hole's made in the zona, then the embryo kind of acts like a little amoeba and works through that hole and can hatch and then be ready to implant. But if it doesn't hatch, it's not going to be able to implant. So that's the reason to do assisted hatching.
Okay, Dr. Klipstein, you had discussed progesterone support.
Mm-hmm.
This question is, why is vaginal progesterone used for the first trimester when doing IVF cycles, but not when you get pregnant on your own naturally?
So it's a very good question. When you get pregnant naturally, what happens is that the ovary releases an egg, and that follicle where that egg is released in the ovary produces progesterone, and that progesterone is made for the first few months of pregnancy, and at that point the placenta from the pregnancy takes over. When you're doing an IVF cycle, there are a couple of things that happen. First of all, when we remove the fluid from the follicles, those follicles that are making progesterone can be disrupted, so they may not make adequate progesterone. And also we give, if you recall, during the part of the cycle, we give some medications to prevent ovulation. And so those may affect how the progesterone acts in the system. And so studies over many years have found that if you don't give progesterone to support the endometrium during that window that implantation should happen with an IVF cycle, and for the first few weeks, at least of the pregnancy rates are lower and the miscarriage rates are higher. So it's really critical to give progesterone during that window.
Okay, I'm going to do one last question per doctor. Dr. Karande, do you recommend doing back-to-back fresh IVF cycles, or do you recommend doing a frozen transfer after a fresh cycle and take a month off in between?
Well, if you do have frozen embryos, then we like to use them up before we do another fresh cycle. The exception would be in patients who are banking their embryos. For example, if you have somebody who is 38, 39 years old, she may want to have more than one child, and rather than come back for a second IVF attempt at age 40 plus, they may want to use their younger ovaries and store more embryos. So other than for embryo banking purposes, I think after a fresh cycle, we would go ahead and use up the frozen embryos before doing another stimulation.
Perfect. Dr. Puscheck, can you tell me the advantages of genetic testing?
Certainly. So with genetic testing, what we're doing is taking that sample of the trophectoderm and we're looking at those 5 to 10 cells to see if they're carrying one of two things. We can do for a specific gene. So if somebody's carrying a gene like for cystic fibrosis or Huntington's chorea or sickle cell or anything that we can actually demonstrate that there is a measurable genetic mutation that we know that you're carrying, then we can test for that particular mutation. And that's called, obviously pre-implantation genetic testing for the mutation. The other and more common reason that we're doing pre-implantation genetic testing is to look to see if there are the right numbers of chromosomes. So normally there's 46 chromosomes, but as you heard earlier that an older woman may have a genetically abnormal oocyte, and so we want to check to see if there are the right number of chromosomes, not too many and not too few. And that's one of the main reasons that women who are older have higher miscarriage rates. So if we do genetic testing on those embryos, we can determine if there's the right number of chromosomes. And then if there are the right number of chromosomes, that's what we call euploid. And that's what we'd want to transfer to give you the higher pregnancy rate, the higher live birth rate, and the lower miscarriage rate. So genetic testing is usually done for one of those two reasons, either looking for a particular gene mutation or to test to see if there are the right number of chromosomes so we can put back the one that's most normal.
Okay, Dr. Klipstein, last question. I've had multiple questions come in phrased differently, wanting to know, what do we do when we have a patient with blocked tubes?
All right, so there are a couple options. The most common option and the most successful thing we do is in vitro fertilization. And so you just work around the tubes. That doesn't, the blocked tubes don't get in the way, except for that the egg and sperm can't meet the old-fashioned way. There is a possibility, and actually Dr. Karande is one of the world experts in this, something called tubal catheterization, where you can, if the tube is slightly blocked, there might be debris in it or a little bit of scarring, you can actually put these catheters in the tube and you can open it up. And so there is a chance of doing that and leading to natural reproduction without any need for IVF. The one caveat there is if the tubes have what's called hydrosalpinges, if they're filled with fluid and they're damaged, you certainly don't want to try to catheterize them. And in fact, sometimes you need to actually remove the blocked tubes altogether because the fluid that lives in the tubes and makes them kind of distended has something in it called embryotoxic factor. And when that goes back into the uterus, that can be toxic to the embryos and decrease the chance of success. But for the most part, it's one of the easier fixes with IVF because you just start bypassing the tubes anyways with in vitro fertilization. So it's no problem at all. We do this very commonly for just that reason, for blocked tubes.
Okay, I'm going to launch one more poll. And it is, did you learn more about IVF from this webinar? Okay, it looks like the answers have slowed down a little, so I'm going to share them. It looks like you guys did a very good job with this webinar. So thank you so much for attending this webinar and for sharing your responses with us. Thank you also to Dr. Karande, Dr. Puscheck, and Dr. Klipstein for sharing this information with us. Please check our website for dates of future webinars. You can also view previous webinars on our website as well. If you have a question that we didn't get to, or if you think of something that you would like to ask after this has ended, please send it to the email address info@nvffertility.com. Stay safe and healthy.